All right, welcome all to the Brain Health and Wellness Initiative series. Tonight, our presenter is Dr. Elizabeth O'Toole, and she's presenting on non-pharmacologic management of behavioral symptoms in dementia. My name is Hannah Doles, and along with my colleague, Nicole Herbert-Hale, we provide care navigation in the JFSA Dementia Care Navigation Program. Our program establishes an empowering environment to help improve the quality of life of those who have dementia or at risk of developing dementia, all while helping family caregivers reduce the stress and burden that often occurs while caregiving. At JFSA, we understand the importance in working with our clients' strengths and applying a person-centered approach to care, which extends throughout our multidisciplinary team of geriatricians, nurses, social workers, and geriatric psychiatrists. Nicole and I meet our clients where they are at and develop individualized care plans that help produce solutions to presenting problems. From linking persons with dementia and their families with community resources to following them with their medical management, we are their point of contact for guidance as well as a listening ear. We consider the intersectionality of one's life when creating interventions that adhere to their biopsychosocial needs and experiences. Just a little bit before we get into the webinar. We will take questions and answers at the end of Dr. O'Toole's session today. I do want to point out that there is a Q&A button, and that's how we will take your questions at the end of the session. So you can type that in, and we will get to those questions at the end of the webinar. Please refrain from using the chat function, and we'll also, again, just keep muted and our video off, please. We're also offering CE credits. So it will take 30 days from the date of your application to issue your CE credit. So you will get a survey emailed to you at the email address you provided during registration. And once that survey is complete, we review that and we'll send you the CE credit. So please use the same email address that you use to register so we know who you are. And of course, if you have any questions about that, feel free to reach out to Nicole and I anytime so we make sure you get your CE credit. A little bit about our speaker tonight. Dr. O'Toole graduated from the Case Western Reserve University School of Medicine and completed residency in internal medicine with fellowships in general internal medicine, clinical ethics, and geriatric medicine at University Hospitals of Cleveland. She is a professor of medicine and bioethics at Case Western. She has over 30 years of experience in medical practice focusing on geriatric medicine and palliative care with an overall goal to support patients and families with individualized care, education, and support. She's practiced at UH, and most recently at Metro Health Medical Center, where she started and directed their division of palliative care and initiated the Hospice and Palliative Medicine Fellowship Program. She has also worked with and directed multiple externally funded research and educational programs. In addition, she has been involved in education and care through many community-based programs, and she has been our geriatric consultant with us at JFSA for several years, and we're very thankful to have her with us tonight to discuss this topic. Thank you, Dr. O'Toole.
Thank you, Hannah. So as Hannah mentioned, I'm going to talk about non-pharmacologic management of psychological and behavioral symptoms in dementia. And the overall objectives of this presentation are to hopefully empower those of you listening to be able to give some thoughtful consideration of these behavioral and psychological symptoms in dementia. And we'll be referring to that going forward as BPSD, because that is in fact quite a mouthful. But I understand that and I want to ask you to spend the next few minutes as we do this. It's a different thing to sort of sit back and try to be giving thoughtful consideration to something that in your daily life, when you have to confront it, feels very different. It doesn't allow you really sometimes the space to be thoughtful and considerate. So this is what we're going to spend a few minutes doing this evening. I'm going to try to identify some common dementia-related behavioral symptoms, many of which you may all be familiar with, but we'll call them we'll just identify them so that we have a list to work with. We're going to try to recognize the adverse effects and risks that are related to these symptoms, not just the experience of the patient having them or the caregiver dealing with that, but there are other effects and risks. And then we'll review approaches to these behavioral symptoms in dementia, including behavioral strategies, environmental adaptations, and a little bit about caregiver training, which is really very important. Next slide. As some background for why this is an issue, not just for individuals who are facing this, but just a worldwide issue, the worldwide prevalence of dementia is increasing as the older population increases, as we're all probably aware. But the numbers really are pretty impressive, 43.8 million in 2016, which is quite some time ago. And at that time, it was a 117% increase over the numbers gathered in 1990. So it's certainly much, much more than that, although on a worldwide scale, I don't have the numbers for it. It's the 5th leading cause of mortality, which is pretty impressive. This is not just an experiential issue. It is a real clinical problem. The majority of those with dementia do experience that should be BPSD at some point, these symptoms that we're talking about. And community dwelling individuals with dementia who have undergone assessment in longitudinal studies, which doesn't represent necessarily the world of community dwelling individuals, but a substantial portion. In that group, up to 97% have been affected by at least one of these types of symptoms. Next slide. So delusions, agitation, abnormal motor behaviors such as fidgeting, repetitive behaviors, and wandering, which are examples of these symptoms, occur in about 1/3 of patients. That's a pretty substantial proportion of a pretty large number. The history is important, so it's useful to know what to look for and be able to describe it. So when we are seeking help, we're trying to figure out what's going on, being able to give the history accurately or as accurately as possible makes a big difference. So understanding the nature and being able to describe the nature of the behavior, the urgency of the need for intervention, what are the characteristics of the symptoms that we're seeing, and do there seem to be, look around for, examine the situation for, do there seem to be possibilities or potentially reversible exacerbating factors? It's easy to get caught up in experiencing someone having the symptoms and witnessing it and wanting to intervene. And we need to take some mental time and see if we can examine some of these other issues. We've all heard the phrase sundowning, which is a very problematic situation, which may affect up to 2/3 of patients with dementia. Next slide. Non-pharmacologic interventions are recommended strongly as the first line of approach to BPSD. Many people will come to seek help with an expectation that there is something that can be given that will reverse this, something that will change it and make it better. Meaning something in the form of a pill or something like that. And that's really not what we think to do in response to these situations. There's no clear recommendation for pharmacologic treatment. Do we have drugs that we sometimes prescribe for these types of symptoms? There are, but they are not clearly recommended for SAME. They are, and we'll talk a little bit more of that later. Some medications are used, as I mentioned, when non-pharmacologic interventions fail. So that is to underscore that we go with non-pharmacologic interventions first. Symptoms are extremely burdensome or even dangerous. Those are the reasons to consider using medications. Decisions are made based on a risk versus potential benefit evaluation. The risks are substantial. The potential benefit is a potential. So you can imagine that this is not an easy decision to make, but we do it after careful consideration and discussion and assessment of values.
Recording in progress.
Pharmacologic intervention has significant side effects, negative side effects, as I mentioned. Sometimes we use antipsychotic meds and some other types of medication, and there's an increased risk of death even, which is a pretty serious consequence. So we have to use these carefully. They may be helpful, but they don't change the underlying illness. So they're not going to fix anything except perhaps some of the symptomatology. Next slide, please. Symptoms. Oh, so we're still on empowering here. Now we're starting we're starting empowering thoughtful consideration after we've looked at that background. So symptoms such as repetitive speech, wandering, and sleep disturbance are core clinical features of Alzheimer's and related dementias. These kind of symptoms are not surprising. They don't signify something more happening. But obviously we'll look to something to might stimulate these, but these are pretty much expected types of symptoms to see in this clinical situation. The BPSD are associated with progressive functional decline, worsened quality of life, increased caregiver stress, and often lead to nursing home placement, which is why this is a particular focus of concern. Early response to such symptoms, identifying underlying causes, and appropriate treatment plans are therefore very important. And I'll reiterate that non-pharmacologic treatments are recommended as first-line approaches. And when those are exhausted or clearly are not working and symptoms are unsupportable, unsustainable, intolerable, then we need to go further for medication. The goal here primarily is to improve quality of life and patient caregiver satisfaction. Next slide. A more in-depth list of the behavioral and psychological symptoms we see in dementia. Probably you're familiar with most, if not all, but we'll make the list anyway. Agitation, abnormal motor behaviors that are related to movement, anxiety, irritability, depression or apathy, delusions, often paranoid, which are particularly difficult, hallucinations. They can be visual more than audio, but they can be both. Sleep disorders, appetite changes. Next slide. Wandering, as we've mentioned, incontinence because of the neurologic issues that are developing with dementia, vocalizations and screaming, which are very hard to tolerate, both for the caregivers and the person experiencing them. And sundowning, which we mentioned. I'll say a little bit more about this. Usually this occurs late in the afternoon or the evening. It's often characterized by the patient becoming more demanding, restless, upset, suspicious, more disoriented, seeing or hearing or believing things that are not real. Next slide. So what should we do in our response to instances of BPSD? Well, first, it's helpful to assess for patient-related factors that might be affecting the behavior. Now, these require the person assessing to step back, maybe not literally, maybe literally, to step back and look at the situation instead of becoming, as a natural human response would be, to become embroiled in it. So in our assessment, we think, okay, what are the feelings I'm seeing? What are the feelings going on here? Is it sadness? Is it fear? Does it seem to be stress? Is there increased confusion as the primary issue? Or is it anxiety? What feelings seem to be driving this, or at least a major piece of it? Are there any physical or health-related problems? Is there some symptom of illness that I'm missing or that isn't being articulated? Because often patients in this situation aren't able to be clear in explaining what their issue is. All we see are symptoms as an expression of distress. Is there pain somewhere? Has there been a change in the meds? Or are there new meds the patient is taking? Has the patient been missing a lot of sleep? Are they overtired? Is insomnia a big problem? If there are any physical or medical concerns, that is a time to seek for medical evaluation. Maybe there's an actual treatable problem. A urinary tract infection can sometimes precipitate these episodes, and those can be treatable if they can be diagnosed. Is there a possible injury, an infection? Simple things like constipation are not so simple when they're being experienced by somebody who doesn't really understand what's going on. Hunger, thirst. Patients with dementia do not really have a good time clock sometimes for knowing that they're hungry and they should eat. Their meals may not be taken regularly. They often are experiencing dehydration. So hunger and thirst are considerations. And problems with vision and hearing. Optimization of sensory, especially vision and hearing, is really critical. If you can't see well, then you're going to make up what you don't see. You're going to take what you do see and create a story around that. Same with hearing. You're filling in blanks, or you're becoming, that's a good reason to be paranoid. You're hearing pieces and parts of things, but you're not making, the whole story doesn't make sense. Another assessment that's important is for environmental issues. Again, in that position of stepping back and looking at the situation, is there too much noise? Is the TV loud? Is the TV show boisterous, or are there arguments happening? Are people yelling at each other? Does it sound violent? Radio, same thing. People talking at once or too loudly. That's very difficult for the patient with dementia to discern who's talking, what is it about. It's just a stressful situation that sounds negative. Is it too light or is it too dark? Is it a comfortable lighting for the person and their vision? Has there been a change in the environment? If they're in an institutional setting, has that changed? Has the staff changed? Have the caregivers changed? Physical layout of the environment. Is the floor level? There may be an angle to the floor that has been tolerated and everybody just goes up and down all the time, but then with dementia, that becomes more of a concern because that level isn't well perceived. Does the tile look different? Does the floor look different? Are the patterns changed? Is the surface type changed? Again, vision can be a big component of this because I would suggest to the person that they need to be more careful, that they become uncertain to interpret what these different patterns mean, even though they may have been walking on these floors for a long time. Mirrors, especially, are known to be difficult. Knowing that's a mirror, a reflection of themselves or some other aspect of the room is not obvious to somebody with dementia and can be frightening. Next slide. This is you. For wandering agitation, consider changing the surroundings, which may allow for more freedom. So pay attention. Are there any dangerous items in the environment? Items that you wouldn't necessarily have considered dangerous unless you were thinking about somebody who wouldn't understand the proper use of these items or their purpose. Pad sharp corners. Get rid of clutter. Mark the edges of steps. As I alluded to before, perception, it can be very different for patients with more advanced dementia. Mark edges of steps to make them clear so people are not as trepidatious about walking on them. Sturdy handrails on stairs. Remove small throw rugs because they're a tripping or a sliding hazard, falls hazard for sure. And use rugs with non-skid, sticking would be okay. Use rugs with non-skid backing and sturdy footwear, which may or may not be okay with the individual with dementia. Next. In terms of the potentially dangerous items, it's, I don't want to be in any way demeaning, but you can think about it in the same way you would baby-proof or child-proof a home. Medications, prescription or over-the-counter, need to be locked away. Dangerous chemicals. What's a dangerous chemical? Well, even household products, matches, cleaning materials could be dangerous if they were misinterpreted and used in a way like eating or drinking that would be dangerous. Alcohol, poisonous plants. Some poisonous plants are quite beautiful, but you have to recognize that you shouldn't eat the plant. Any kind of weapon, certainly guns and true weapons of that type, but also knives, scissors, tools, machinery, which could be used to harm somebody else, especially in agitation. Thank you. So what other ways, besides assessment and dealing with the things that you might find or one might find that could be changed that we just went over? What can we do as an action? These seem, some of them, to be quite simple and natural to do, but in the situation of being confronted with somebody who is having some of these symptoms, again, it takes a little bit of effort to calm the caregiver or the other person in the room down, to be able to do the assessment we talked about, but to also take these actions. So reassure the person by using calm phrases. When somebody's screaming at you, the temptation is to sort of scream back. So that's not the right thing, of course. Reassure the person by using calming phrases and letting the person know you are there and you are there for them. And maybe who you are, even though they should perhaps know, and it might be painful to have to acknowledge that this person doesn't know who you are. Allow adequate rest between stimulating events. Too many things coming at the person may be a cause for stress. Use lighting to reduce confusion and restlessness, especially at night. Misperceptions of the environment when the lighting is not appropriate are common. Involve the person in activities such as art, music, or therapeutic touch to promote relaxation. Try to focus on simplified tasks and structured routines. It's nice to do new things. It's nice to do something interesting, but it has to be done sometimes in a simplified way, step by step, and see how acceptable it is to the person. Find outlets for energy, such as taking a walk, doing household chores, sometimes together with other people, meaningful activities and meaningful for the person at the level that the person can participate and appreciate if possible. Also, I mean, this has been tried in many instances with success. I think we often feel that this might be demeaning or kind of juvenile, but it's actually helpful in a lot of situations to use signs and labels to cue or remind the person. So a sign about this is the light switch, lights on the wall, in big enough print to be useful. Simple things like that. This is where we put the clothes. This is where we do this. Allows the person to be a little bit more independent, perhaps, because they can make more sense of their environment if they're able to respond to these written cues. Next. Having said that, what would be training examples for caregivers? All training for caregivers is really focused on understanding the disturbances that the person is demonstrating as responses to some kind of discomfort, some unmet need, some attempt to communicate. Underneath this is a brain that's not functioning properly. So they're getting information and they're processing information not correctly. But the disturbances that you're seeing are a reflection of that. And that does result in discomfort, unmet needs, which may just be safety in their own minds, that they're not feeling safe, excuse me. And it's a way of communicating. So what are some of the responses that we could have to those situations? If at all possible, create soothing environments with optimal levels of stimulation. And that's not a one-time thing. That's kind of a general response. Use strategies to de-escalate problematic behaviors. The most useful strategy is really distraction. People get upset about things. They've lost something. They are not sure where they are. They're worried about somebody who may not even be alive anymore, and distressed about that. If there's another area that is of interest to the person, there may be a point in the conversation where you can just switch or bring that other topic up. Perhaps it's that going for a walk that was mentioned on the slide before here, and change the focus of what the person is fixed on. And it's surprising how well that can actually work. And it's definitely one of the first things to try. When trying to accomplish a task with the person who has become more symptomatic in the ways that we've been talking about, make sure that your instructions are clear. No more than 1 or 2 steps at a time. Simple choices, yes, no, blue, green. Not lots of complication, or really any complication if possible. If people can follow these instructions and simple choices, not only does it move things forward, but it also gives them a sense that they've accomplished something, that they can participate, that they have some control. As you can imagine, people with dementia who are at the point of experiencing these symptoms do seem to feel out of control. And in fact, they are out of control. And the truth of it is that the caregiver is trying to reestablish both their own sense of control and the sense of control of the person. Circadian rhythms, which we are kind of familiar with, because we all know that when we don't get to bed until too late, or we get up too early, or we don't sleep at night, that we aren't so good. We, meaning those of us who thankfully at the moment are not experiencing dementia. Those are part of the dementia process, those disturbances. So, but we can use light to try to reduce circadian disturbances, to kind of reproduce where the person should be in their day in consideration of the time. So make sure that it's at night, it should be relatively darker. It should be quieter. And in the daytime, it should be lighter. And as we talked about, the noise level control, but still more activity in the daytime. Next slide. Reminiscence therapy has been very successful for many people. It's pretty simple. It involves reviewing the past of the individual in any form, conversation. Remember Uncle so-and-so, or somebody you feel like would be somebody that the person could actually respond to a conversation about. Looking at photos, looking at albums, and at a time frame that perhaps the person is fixed on. Music in general, if there's a type of music that the person really enjoys, or and it can be used as a distraction for sure. Or if there's a music from a time frame that is important to them. Again, we talked about simple tasks in terms of giving instructions, but also simple tasks like folding. I can't tell you how many hours I spent with my grandmother as a young person. She had been a maid in one of the hotels, and so folding sheets and folding towels was wonderful for her, and I learned how to fold them right. So it was a good thing for me, it turned out, as well. Busy quilts, which you may or may not know, they're sort of made with little tasks on them that people, buttons, zippers, things of that nature, that people can, they're not playing with it, they're actually helping with their dexterity and giving them some kind of activity that makes sense to them. There's also aroma or music therapy, which is music therapy is even more specific than just playing music. Now, in some of the lists that are in the literature, it also includes not rewarding worrisome behaviors, which I put it in here because if you look it up, you'll see it. I don't like it. I mean, who am I to say? But I don't like it. These are not. I mentioned that some of the protections and looking at the environment are similar to protecting for childproofing, but just because dangers are similar, we're not dealing with children here. We're dealing with adults, and one of the biggest issues that these adults face, whether they can articulate it or not, is their loss of independence and dignity. So I do not think that not rewarding worrisome behaviors is appropriate. We're not training somebody in that way. I do think that worrisome behaviors have to be addressed in terms of safety, but distraction and all these other things are a much preferable thing. I don't. When we start thinking in terms of not rewarding, we're not thinking, in my opinion, we're not thinking right. We're not thinking as a partner. We're thinking as somebody who's outside of the situation. And most caregivers, I think, do better when they see themselves as partners and trying to facilitate things for the individual rather than controlling in this kind of external and paternalistic way. Next. Whatever approach you need, whatever approach is taken should be patient-centered. Again, I know I'm sort of harping on the same topic a little often here, but it's kind of critical. And that is that although we are wanting to help caregivers, critically wanting to help caregivers, the way to help a caregiver take care of the patient is to be patient-centered. That's where we're going to find the best solutions, the most helpful solutions, and we get to do the right thing at the same time. So caregivers who know and care about the patient are uniquely able to be helpful and interpret appropriate responses. The first questions I ask, I'm sure it's the first question that most professionals in this field ask when somebody is experiencing these symptoms is, tell me about this person. What's important to them? What do you think are the triggers about this? What happened that set this person down a path of being agitated? What insult did they perceive? Or what in their life is so important to them that we might miss, that might be contributing to what we're seeing in front of us? Family caregivers, even though the person may or may not recognize them, may or may not know the name, there may be some kind of a familiarity that is underlying that can be very useful. That caring connection can't be minimized in terms of its importance. From the caregiver point of view, and this is really tough for professional caregivers as well as personal or family caregivers, slow down. You have to tell yourself, you have to just say, push the pause button and slow down. It takes longer to do things. It's just going to take longer to do things. So we have to figure we're going to have to slow down. The more you try to speed up to make up for lost time, or because time is time and it's limited, the deeper in trouble we're going to be. Attend to what might be the patient's history and experience of the situation. So again, this is related to what we know about the person. What is this representing? What piece of what we're seeing in front of us is representative of something else that means something to the patient? We can address that. We might be able to turn the whole situation around. The next one, I think, in terms of recommendation and responding, I think is wonderful, and we should remember it, and it's to smile. People understand smiles. It's a language that it doesn't actually make any difference what the person's primary language is. People understand a smile. Even when people are pretty impaired or in distress, most people, not all, they might say, "What are you smiling about? There's nothing to smile here." But most people will smile back at you, or will at least appreciate that this is a positive person. This isn't a threat to me, and be willing to perhaps engage in some other conversation with you or a different activity. And again, as mentioned before, attend to the environment and safety. That we can't overlook that we can't overemphasize that. Next slide, please. Also important, and we need to underscore this, is that caregivers must attend to their own health and their ability to tolerate the stresses and issues that they encounter in dealing with caring for a patient who's experiencing these symptoms. That's not easy to do, particularly if you're a solo caregiver, or there aren't a lot of folks around who can depend on to take this task on. But it's sort of like in the airline, when the oxygen comes down, the stewardess, dating myself here, the attendant will say, when you do the safety precautions at the beginning, put the oxygen on you first, then attend to those who need help. And you can't provide thoughtful care if you're not able to tolerate the stress, if your own health is in trouble, if you have other issues that you're encountering. So paying attention to that is not a failure of caregiving. It's part of being a good caregiver. So that's not something to be felt bad about, but to be seen as an important part of the function of a caregiver. You have to attend to your own issues and recognize them. Now, is that a simple thing to do? No. Are there people around to help? Hopefully there are. I know the folks here are certainly part of the group who would want to be part of assisting with that situation, and certainly would understand. Sharing burdens when possible may be helpful, depending on how acceptable sharing of burdens is to the people involved. But I would invite people to give it a try. It may work for you, even if you're not so sure that that's something you want to try. Think about it. Caregivers should also seek assistance with strategies and coping when needed. So maybe you're confronted with something you've never seen before. And there may be people who've seen it plenty of times. Maybe strategies that just didn't occur to you, but somebody could help provide them to you. Coping strategies, and also strategies to change the situation or to address the situation itself. It's very important, but often difficult, to remember that these symptoms are a result of the disease, the underlying brain disease. It's not volitional on the part of the patient. Are there problems with controlling emotions and saying things that you maybe if you had more control, you wouldn't on the person's part? Perhaps. But that is, again, part of the disease. So I have people tell me so often, why does she hate me? Why is she so mean to me? This isn't fair. I do so much for her. It's not volitional. She's not trying to be mean to you. She's not trying, I don't believe, most of the time. She's not trying to, it's the disease that's not letting her process things appropriately. It's not intentional to hurt the caregiver, for the most part. I'm not a mind reader, of course. And people who have been mean all their lives, I'm not expecting them to be charming when they have dementia. But it's not impossible either. So think about it. But don't take it personally, is what I'm trying to say, because that's hurtful. And it's very hard when you're hurt to be a caregiver in a difficult role that is required of you. It's also important, the phrase good days and bad days is used very frequently at this situation. And that's kind of how it goes, which is all the more frustrating because you want them all to be good. And you know that if you had a good day, then a good day is possible. So why isn't every day a good day? It just isn't. It's the nature of it. So I think what we can do is we can value those good days and cherish them. And then we can see what we can do to get through the bad days when they occur. So it's important to evaluate and reevaluate, as behavior and abilities may change over time as well. It's not just one day and the other day are good and bad, but over time, over weeks, over months, we do see behaviors and abilities change, and that requires some evaluation and perhaps change in the way we approach things. Next slide. There was a slide in between, I thought. Okay, well, I looked at a number of references for this. These are some of the ones that I thought, if anybody's interested, they would be pretty available. The National Institute on Aging, which is the third one down. Is online, of course. Actually, all of these are online. But the Alzheimer's Association also has some good reference materials online. Next slide. Is there a next slide?
that time of the night where we take questions. Yes. Thank you very much, Dr. O'Toole. That was very informative. If our audience has questions, we will take them using the Q&A chat feature, which you should see on your toolbar. And we will not be unmuting ourselves to ask questions. So if you can please use that Q&A chat. All right, we have one. Okay. A family member I know is incredibly worried that he will pass away before his wife with dementia does. He has cancer and knows this may be possible. It is on his mind every day. His wife is in a dementia facility, but the man is almost sole caregiver. He is there every day for her for about 3 hours. Thank you for sharing that.
Was there a question or?
Did you have Holly, I know you're the one that wrote that. If you have any questions about that for your friend, please let us know.
While he's doing that, that's a terribly sad story. I'm very sorry to hear about that.
Oh, she asked, what advice can you give him about that situation?
Yeah. I don't know if it sounds like his being there every day is what he wants to do and perhaps needs to do. I don't know in which case, we live our lives often for others. And if we're capable of doing it and it's meaningful to us, then as long as that's possible, that seems like reasonable. It sounds like he's more concerned about what happens when he can't do that for her. And I don't know if he has any other people available to engage with her, or if the staff at her place can be helpful to him in terms of partnering with him in being there with her, so that if he sometime is not there, that he will know who is going to be there for her, or family members, or any religious organization he might be a member of who would want to take that on some way. Community organizations that might help support both of them for the current situation and into the future. It's a very difficult situation, and unfortunately, not everybody has people as devoted as he. But it is very hard on everybody, and I am very sorry for them.
I hope he can get some support, because I'm sure this is very challenging for him to be doing on his own, if that is the scenario.
If the facility can be, there may be people there, a social worker, somebody who he could talk to if he hasn't already, about support and options for finding a comfortable plan for him and his wife.
I hope all goes well for your friend, and if he needs any resources wherever he is, I'm sure we can maybe help him get a couple resources too. Someone else asked, what is your view on the Montessori dementia training approach to caregiving? Are you familiar with that?
You may be more familiar with it, Hannah. Go ahead.
I'm sorry. I have looked into it a bit, but I'll be honest, I do not know about the whole program.
I think any caregiver training program that is supportive of respecting the individual and supporting the caregiver is worth looking into. I know that there are different, the Montessori, I'm more familiar with Montessori as a school technique, and I'm assuming that, you know, those techniques are not dissimilar. So it's whatever empowers good care and care of both person and the individual, and works for people. I mean, there's no magic about it. But I'd be interested in hearing if somebody's had experience that they wanted to share. I've never been through their training.
Yeah, we would like to know more if anyone has seen that. Families are often looking for a cure for dementia. Are there good approaches for to explaining to the families that what the current medical situation is?
It's not funny, but it's tantalizing is what it is. Every day I look at my email, and every day there's one or two articles about what about this, what about that, what about the other thing. So I guess the good news is that there are lots of things that are being looked at seriously, and by things I mean actual potential medications that are being explored. And as I'm sure folks know, the FDA has approved one and is likely to approve a second medication. These are not cures. These are not anywhere near cures. Their goal is to delay some progression, and they're really only targeting early stage. So they're not going to be available for most people because very few people present at early stage. Although I'm thinking that if this becomes more available and more popular, and people will be presenting earlier than they do now. But there are a lot of reasons why people don't present early. So we'll have to see how this works out. It's not a huge boon, but any delay in progression is time. It's really what's been demonstrated in the trials is more along the lines of months. So it's not, you know, fantastic, but it's something. And then there are I got another email today about a different approach to things, which was more upstream from the target of these two drugs that I just mentioned. So that actually, if that's real, but it'll be years before that is determined to be real or not. If that kind of thing is real, that might be something more useful. But to know that people are seriously looking at this, that these things will be considered and is good news. The side effects are not great, but that's true of almost everything. So I guess there's hope, but it's not, I guess I wouldn't say it's really on the horizon. It's a little bit beyond the horizon, but people are seriously working on it, and I think there is hope, but I can't say that there's anything really, truly super beneficial right now. Is that anywhere near what the question was asking?
I do believe so. You give your patients hope, it sounds like, but I know you have to be upfront with your families about what the options truly are at this time frame.
Right. It's easy to get excited because my goodness, the whole world would like to see this go away.
Of course. Of course. Another question, someone was asking if dementia or Alzheimer's disease, if that is hereditary.
There's a small percentage that is. Not hereditary in the sense that it's 100%, but hereditary in terms of an increased risk. So you may have heard of ApoE, which is a genetic, which is genetically related. And that's one of the testing that can be done. The problem is if you test positive, there are a couple of genes. So you can have one or you can have both. Obviously, the risk is greater if you have both, if you test positive for both, but it's not 100%. So it's something that would have to be thoughtfully considered. But it is available, testing for the genetic component. But that is not the majority of people who develop dementia.
Thank you. We have time for one more question. Are there any thoughts concerning moving someone from a solitary home situation to assisted living when they're not interested in giving up their home situation?
Oh boy, lots of thoughts. This is not an uncommon circumstance. In fact, when I have a patient who says, you know, I think I need to move to assisted living because I'm not thinking right, I wonder about their thinking, because they're so far different from most of the patients. Very few people want to leave their home, but to be fair, some recognize their situation, and actually one of the motivations is to protect their families. They recognize the stress, they recognize the safety issues and are looking for they know that they're overwhelmed and they need some more support. It is a very challenging situation, but it is common, and it is something that sometimes we just have to do because the person simply is not able to be at home anymore. They're experiencing severe distress often at home. They can't manage. They're failing physically often. They're frightened often. They're confused, which is distressing in and of itself. And sometimes the goal is to engage the person in decision-making as much as they're willing to be, but that this has to happen, that this isn't, it's no longer would you like to or not. It's, would you like this place or that place? Maybe. It's, what would you like, what's important to take with you? The choices that are reasonable and can be made, but the choice of staying home is sometimes just no longer a choice. And that's very hard, but
Absolutely. Absolutely.
it has to happen sometimes.
All right. Thank you. I'm sorry. We that's all the time we have for questions tonight, but thank you, Dr. O'Toole, for your time. If any of you have additional questions, please feel free to email Nicole or myself with them. And I can certainly pass those on to Dr. O'Toole, and we can email you some answers back. So we would be happy to do that. A little bit more about our programs here at JFSA. As you know, we have an extensive dementia support program, not only for the person with dementia, but also for the family caregivers. And Nicole and I work very closely with people in the community to make sure they're safe at home, getting the supports they need and the services they need in place. Dr. Elizabeth O'Toole and Dr. Constance Magulius are two geriatricians that work with us here at the Allison's Place Clinic at JFSA. And if you are interested in having a loved one sign up with them, we can certainly talk with you about that and how to make an appointment. Also with us on our team is Dr. Frank Petrelli, as well as Pamela Lynch and Leanne Stuver. Frank is our general psychologist. He does our cognitive evaluations. Pam Lynch, you may recognize her from our Caregiving with Confidence workshop, as well as our support group facilitator. And Leanne Stuver is one of our health educators who will come with, who will attend our brain health and wellness presentations as well. In summary of our resources with our JFSA programming, you know, Dr. O'Toole touched a lot about different interventions that you can try with a person on when they're having different behavioral symptoms. We go over that heavily within our Caregiving with Confidence workshop. So if that is something that you or a family caregiver that you know of is struggling with their loved one, this 6-week course that we offer definitely delves into that, as well as self-care for the caregiver throughout the journey of this dementia diagnosis. So we do want you to know that that is available to you as a resource if you want to participate. And we do have another workshop coming up in August, if you are interested in signing up for that. We also offer an ongoing support group twice a month on the second and the fourth Monday of the month. And that is another way that hopefully you can come and share ideas with each other and other family caregivers. The care navigation piece, where Nicole and I come out into the home, that's another big part of the program, as well as our JFSA home care services, such as aides, nurses, and different therapies. And then, of course, our brain health and wellness series presentations. And next month, Dr. Dennis Grossman will be with us presenting on dementia and the divided brain. So we will be meeting on August 24th at 6:30. So a email registration will be going out for that shortly. And again, if there are any questions, please feel free to call or email us about anything from our presentation tonight. A survey will be going out within the next few days, and we will be attaching these slides for you to review at home. So thank you, everybody, for coming. Thank you, Dr. O'Toole, for your presentation tonight.
Thank you. Thank you for running it, and thank you for those who were listening and asking questions.
All right. Thank you so much, everyone. Good night.
Thank you both very much.